fellow healers, physicians and lawmakers, aides, members of the press, and policy shapers, I am humbled to be in this great room where giants have stood before. Lawmakers, know that we understand you give a sacrifice to even run for office and a further sacrifice to serve. Despite that time and energy, you have been vilified by the press and the public, especially regarding healthcare policy. We at Practicing Physicians of America are the healers of America, actual practicing or retired practicing physicians, and we are here to help serve. Because if you fix healthcare, lawmakers, responsibly, transparently, in a bipartisan manner, all Americans will benefit, and you will be well remembered for it. Welcome to an event that has been put together in 2 weeks by physicians and compatriots who care very deeply about their patients and their profession. And we are untainted by special interests, bound to serve our beloved patients first. What happens between a doctor and a patient is so very personal. So let me take you back 20 years. I've changed the names for protection so I can share a very personal story. Let me take you to the pediatric intensive care unit at Northwestern Memorial Hospital of my training. It was 2 a.m., and after chest compressions and rounds of epinephrine, we called the code. As the team began to clear the syringes and vials off the lifeless tiny body in an oversized bed, I pulled off my gloves and crept across the open ward to a drawn curtain. 11-year-old Kenya, name changed, wide-eyed and overbreathing her ventilator, lay behind the curtain. It was an open ward, so she knew what was going on behind her curtain. For weeks she had existed, alert on the ventilator, waiting for a heart. She lay, tears welling up in her deep brown eyes. Of course, on a ventilator, she could not speak. I learned to read her eyes. When she felt ambitious, she would point to a speech board or write something, and exhausted, need a nap. I found her hand and squeezed it. I could see in those eyes she understood that just paces away, a fellow child had died. You are okay, I reassured her. We both knew I could not assuage her worrying that one day death might find her too. Your heart is coming, her mother would say, as she came each day to read Kenya letters that friends and family had written to her. As the days bled out and dragged on, Kenya and I would take field trips to the CT scanner. Can you imagine that that's your excitement for the day, a field trip to the CT scanner? On one such excursion, we placed her in the scanner, and I walked out to wait. Suddenly, as the scanner moved, I saw her hand twitch. Something was horribly wrong. I raced in and knew her breathing tube had dislodged. Kenya tried to grab at her throat, but weakened, couldn't even manage a gesture of panic. I had little to help. I had nothing to reestablish her airway. I was barely out of internship, and the horror of my own helplessness rose around both of us. I pushed the code button, pulled out the tube that once keeping her alive was now blocking her airway. I grabbed an oxygen bag, and yes, I prayed, while her eyes, locked on mine, registered the pure fear of death. The team arrived and managed to resecure her airway, a team far better than my singular and meager abilities at the time came to save Kenya. A team was needed, a team arrived. We thought her time had come, but we cheated death that day. Kenya's parents continued to come and read letters to their daughter. Most nights, she lay awake alone. Even though she couldn't speak, I don't think she would have complained. Not in her nature, her mother told me. It was not in her nature to be anything other than a sweet 11-year-old girl, innocent, waiting for a miracle and subsisting on mercy. I share this story because this is medicine. I remember it like it was yesterday. These are all details that are inside of me, although it was 20 years ago. All of us in medicine recall multiple poignant stories such as this, It's one of the great gifts of a beautiful profession. I share this story to refocus you as a nation, which is actually an intubated child needing a heart and a team, and me as a singular doctor right now speaking for patients who desperately need a team. I have learned we have a team. In the 2 weeks that this program has come together, yes, that's right, we got this room 2 weeks ago, and I learned that we have a team of American healers. Lawmakers, you represent part of the team that's coming to the code. Please come to the call of this code button. Make no mistake, American medicine is in the intensive care unit. Today, we introduce our team of the Practicing Physicians of America. We represent tens of thousands of doctors, and make no mistake, we have reached to hundreds of thousands more. And we are here in the service of our patients and our profession. Lawmakers, come to the code with us. Kenya could not eventually hold the ground merely intubated. She bought 2 more weeks on a left ventricular assist device, so weak she was sedated and paralyzed. Those eyes closed in a medicated sleep. Every day, her parents stayed optimistic, yet her days turned dusky, as did her skin, as she lost the pink of life. Your heart is coming. You will heal, her mother whispered. The heart never came. On a cold April day, her loved ones and doctors came to her bedside and turned off the machines. It was quiet for a moment, and then one physician spoke. Kenya has the only heart not hurting now. I'll bet every nurse and healer in that room that day hurt, and I'll bet they still remember that day and this story. Because as so happens often in medicine, our patients become a part of us forever. Because medicine is personal. It is not about a repeal, a replace, a certification, a box we are forced to check. All of us, physicians included, are patients. All of us will someday walk the path of death or hold the hand of a parent, a partner, a sibling, a child, or a friend who must do so. Who do you want as your healer guiding you? An administrator, an executive, a lobbyist, or someone who chose the path of years of learning because they desire to serve their patients? I thank you all so much for coming, because we gather today, doctors, the press, aides, lawmakers, healers all, to find as a team the new heart of medicine and save the innocent child, the collective patient. We come together to do something with the adrenaline in our bodies and the bond we feel with human suffering. Kenya needed a team and hope and a new heart, and America needs the same. Allow us to keep our Hippocratic oath to serve our patients. We're doctors, we're not lawmakers, but we can serve the essential function of sharing our collective knowledge of our craft. We are here to directly inform you of what stands in the way of better health for all of America. Please serve the public that elected you, the Constitution you swore to defend, and not the almighty dollar that is thrown upon you in the name of re-election. Please transplant the heart back into the patient. I am honored to introduce to you our team that today represents the Practicing Physicians of America. Our first speaker is Denai Powers. Denai is a practicing anesthesiologist in central Pennsylvania. She is the president-elect of PA Medical Society, and she is going to speak on the pitfalls of quality measures. Thanks, Denai.
Thank you, everybody. I just told Mary and I teared up. That's very hard to hear that without feeling the emotion. And she's right. That's what we as physicians feel, and I think it's what our patients want us to feel. When Marian asked me to do this talk about quality, I sat down and wrote multiple versions, and every single one I ripped up because there's so much to say about the pitfalls of quality in medicine today. And I decided what I'm going to do is just start talking, and tell stories and then take questions. So here's the thing. I was accepted into medical school in the 1970s. And what I know now, I did not know then. I thought I knew a lot when I got out of medical school and became a physician. And I had a lot of ideas, and every single one of them was right because I was so smart. But what I have learned is it's not what I got right that taught me things, it's what I was getting wrong. And I can tell you, in the healthcare system of America today, we are getting many, many things wrong, put there by well-intentioned people who know they're just as smart as I knew I was when I came out of medical school with that MD degree. So how are we making these mistakes? And I'm going to talk to you about some of the stories, some of the information, and some of the conclusions I have drawn. And I'm going to say I've drawn those conclusions over the years. I did not know 2 decades ago what I know now. But my motivations have stayed the same. They're the motivations that Dr. Moss just talked about. It is our patients that we love. It is the reason we went into medicine. And it's why we spent more years in training than it took us to go from kindergarten to graduating from high school. And it is what motivates physicians. The majority of physicians in this country are not coming in for the money. They're coming in for the love of the profession. And we are an ancient profession. We go back to the time of Hippocrates in our traditions. And that is why we go to work. And you have to pay a whole heck of a lot more money to a physician to show up at work when you have taken their motivation from them and given them the motivations of the bureaucrats, the insurers, the legislators, and those with perverted interests. So let me start. I'm going to read something to you and see if anybody here figures out what it's from. Observers have suggested that quality of care in the health system has been bolstered by concerted efforts to track performance measures, expand the use of health information technology, manage chronic diseases, coordinate care by different providers, and enhance the provision of evidence-based medical practices. The lessons learned by this organization have implications for other components of the nation's healthcare system. The major focus of the transformation was the tracking of a number of performance indicators, including quality of care measures, and holding senior managers accountable for improvement of those measures. Does anybody recognize what that's from? Okay, let me keep reading. The organization uses health information technology extensively to implement the primary care model. We use a suite of health information systems, including electronic medical records, computerized physician order entry, medical imaging, diagnostic test results, pharmaceutical management, staffing, and a wide variety of other applications that support the organization's hospitals, clinics, and nursing homes. $100 billion was allotted, and we used these resources to pursue excellence in the care, quality, services, and benefits we provide. The strategic plan established our enduring principles: people-centric, results-driven, and forward-looking. Does anybody recognize that? VA. Okay? Sounds good, doesn't it? Sounds great. It had all the right buzzwords. And I'm sure the quality measures showed all the right improvements. What do we now know about the VA, and how did we find it out? We found out about the VA because people on the inside came forward and said there are separate lists where the real data is being hidden. There are agendas that you don't know about that we're forced to do. And oh, by the way, we don't even have to talk about expensive care, unnecessary tests. There are people who've died because of this. And people have pinned this on the VA. They have sat there and said, this is a horrible system. Look at these awful, rotten, terrible people. But I want to tell you something. The VA is not unique. What is unique is they were found out. Okay? This is going on in every medical system in America. Pressure coming from above to offer quality, to do measurements, to give numbers, to get paid for those numbers, to get promoted for those numbers. And underneath is a story of patients being hurt and doctors and nurses being silenced. Do you get where I'm going with this? So I would like to tell you about my journey into this. I trained in the 70s, so I've been around a long time. This is where everyone says you don't look that old. Thank you very much. It's the part that makes me feel good. I've been in academics. I've been in state-of-the-art research centers. I started transplant programs. I taught residents, did medical research, and then for family reasons moved to rural America and started a practice in a small town hospital, and then in rural medicine. I've seen a heck of a lot. Now, every single place I've ever been, there have been medical mistakes, errors, and substandard care. But in the beginning of my career, when something like that happened, it happened once. The doctors got together, the nurses got together, and they said, this was not good. Even if the doctor or nurse who had created the problem didn't care, the other doctors or nurses cared a heck of a lot, and they brought the hammer down. It was done in private, it was done behind closed doors, but it was addressed. Somewhere in the mid-90s, I entered a system where I started seeing problems, and I'd like to read you. I didn't realize there were going to be so many doctors here, or I would have brought medical stories where if you understand the medicine, it's appalling. But I brought stuff that I think lay people would understand. And this is from a quality assurance program that was kept by a nurse. It never rose to the level of actually being reviewed. Patient asystolic, that means the heart's flatlined. Surgeon doing cardiac compressions. Anesthesiologist asleep. Nurse wakes up anesthesiologist. Let me read you another one. Patient recall. Patient states she felt the incision and was terrified because she couldn't move. She was even awake when the doctor said, twin girls. How about this one? Spinal did not take. Anesthesiologist did not put patient asleep until it became apparent baby could not be delivered. Post-op patient stated, I was in so much pain I could have screamed. I felt everything, but I couldn't move. Husband was irate. Why was she put through this? The last one, and this is just one of hundreds. Patient recall, general anesthesia C-section. Patient not able to move, yet felt excruciating pain, didn't think she could stand it. Anesthesiologist had a leak in the anesthesia system and didn't have the anesthetic in the machine, okay? This sounds pretty bad, doesn't it? There were doctors in that system that complained. We complained about the anesthesiologist's leadership, the head of the department, I was in this department, and what this doctor was doing. Let me tell you what our administration and board did. This doctor, the doctor doing this, and we'll call him Dr. P, has been frequently challenged because he took strong positions which were essentially the board's positions, which is basically what he is paid to do as director and chairman. Our complaints about his quality were presented as we were difficult and disruptive physicians. Now, I subsequently left that facility, but not because he was replaced, because we realized it was a place we were no longer welcome. When this was going on, I called my parents up. They have 2 children who are physicians, me and my brother. And Marion, by the way, keep track of the time because I talk a lot. So just stand up and jump and yell or whatever at 5 minutes. Anyway, I had called my parents up in the late 90s and said, be very, very careful. When you go to the hospital or a doctor, get a hold of me or my brother because things are going to get very bad. And my parents have said to me, how did you know? And I said, because I saw what we couldn't fix in that hospital. I realized that the power had been taken away from doctors. Most of the doctors and surgeons were appalled by this person, but he was protected by a system that no longer understood quality, okay? So there was nothing we could do. And when I saw that and recognized that the power of the law had come down on the side of the doctor doing the bad care and had come down to silence the doctors and nurses trying to do the good care, that we were headed for trouble. And it came down on the side of the bad doctor with all the verbiage of that stuff I just read you from the VA. I've heard from doctors all over the country with these stories. They don't go public with them because they can get fired. Listen to this. This is from a physician who was chief of staff at a hospital and subsequently retired. But in his retirement letter, he wrote, we've had many quality issues surface during my 2-year term, and in my opinion, we have not handled them properly and thoroughly because of the insensitivity of our board of directors and administration to patient health, safety, and welfare. Many of us in the medical staff practice good quality medicine, but the standards for our hospital are set by those who do not. Yeah, 5 minutes. Okay. Anyway, I think I've given you the background here. I have lots of other stories, but what I'm trying to tell you is these quality measures don't work. I have a story in here from Tennant Reading where had great cardiac bypass numbers, but they were bypassing patients with normal coronaries. I don't know if you heard that story, but those give you great numbers. Doctors are being employed. They're being driven out of private practice. We have a horrific system called MACRA and MIPS that is going to do way more damage to patient care than anything has done to date. It will destroy our ability to put patients first. And this is the word we have to get out to people. I can take questions if anyone has any. Thank you. Yes.
What do you have an idea? Why do you think they're trying to drive private practice out of business?
Because
it seems a concerted effort.
they've been sold this story that the reason medicine is expensive is because doctors are overdoing it and we're not policing ourselves. And that's a story. The reason medicine is expensive is because middlemen have come in and have had the time to go to legislators and say, we can bring the cost down, and we'll do it by increasing quality so you won't be rationing, or if you're rationing, you'll be doing it the best way possible, and let's put some metrics in. And oh, by the way, we'll make money off of the electronic medical records, we'll make money off of MACRA and MIPS, we'll make money off of MU, meaningful use, which doctors call meaningless use in private. And so they've sold a bill of good to a bunch of people who don't understand what the practice of medicine involves, which is it's complicated, it's individual, it takes years of training and expertise, and without the understanding of the doctor, you never order the appropriate tests. So they don't want doctors involved. If you're running a hospital system, you want as many test orders as possible because you get the money, right? And so they don't want us in this system, and they've sold it to people who believe them because you couldn't possibly be here in your own personal interest. You've got to care about patients. And doctors have been traditionally too busy to get involved. That's just part of that is our fault. Yes.
Both sides, and it, on the surface, just like the statement, looks good. What kind of data or information can you give to the Republicans who put this in that they need to get rid of it?
Let me tell you something. MACRA and MIPS was supported across the aisle, not because anybody paid attention to MACRA and MIPS. It was tagged onto the repeal of the SGR bill, okay? So I get tired of hearing of this bipartisan support. People didn't pay attention to MACRA and MIPS. They were pushing repeal of SGR. I wrote to the AMA. We wrote to we wrote to people in organized medicine, and I'm going to be president of the Medical Society in 2019. We wrote, they didn't hear it because they were so anxious to repeal the SGR that nobody looked at MACRA and MIPS. And MACRA and MIPS is going to destroy the ability of doctors to put patients first, and it's going to do it at great expense. But there is no, quote, data other than the knowledge that the system is meaningless. It's useless information that's going to be promulgated up the chain that cannot be individualized and that will impede a doctor's ability to act in the interest of the patient. But when you say bipartisan, I'm sorry, it's just SGR repeal was bipartisan. Nobody really looked at MACRA and MIPS. They didn't hear from doctors on it. They heard from what I call the bureaucratic doctors, the yes men, the middleman, the one who wants the money. They didn't hear from practicing physicians. And when practicing physicians found out about MACRA and MIPS, they were stunned, but it had already become law. Does that answer your question? Right. Well, we have to take the time, talk to their staff, and educate them. I'm sorry, yeah, what? Right.
And I suggested to many lawyers, why cannot we repeal this? And I'm told time and time again that it's because, it's a bipartisan bill, we all voted for it. What I have to say is this, as physicians, when we make a mistake with our patients, we have to go back and tell the patients, we didn't do the right thing, wasn't pneumonia, it was really wheezing. And with that, we're apologizing to you, we get you on the right track. But you know what? Lawmakers are professionals, and they need to be held to the same standard. We made a mistake, this is a terrible mistake, it's going to affect patient care, so therefore, we're going to repeal it. I don't see why this is a problem. And
I agree.
Go back and repeal SGR as we
Yeah, I agree. That's 100% correct because MACRA and MIPS are going, I can't say this enough, they will destroy the practice of medicine. You will end up with patients being harmed. You won't get the information because the quality measures don't pick that up. They're not designed to measure the quality of the quality measure itself. And it will drive the independent doctors out of practice. And without independent doctors, you do not have health care. You just don't. I'm not saying you can't have employed physicians. You need both. You need the large systems, but you need the option for doctors to move in and out and nurses to move in and out. And speaking of nurses, one quality measure that I'd love to see is staffing. I mean, the main reason we have some of the issues we have in medicine is we don't have adequate staff because there's no quality measure that says there were enough nurses to pick up the problem the patient had or give them the medicine on time. So what the heck? Let's not have enough nurses. Yes.
We discussed the matter, and Seth told me that Representative support matter, and today support matter, and has evidence that it is in fact good. It is going to be good for medicine, that what we believe and what we are saying is wrong and incorrect. So what I talked about was there is room for dialogue here. Somebody asked, how are we going to go through and tell them exactly what to do? I don't know if you can tell them exactly what to do, but at least we need to engage in dialogue because they believe that what we believe is wrong. And that the implication there is that they know better than we do. And we don't want to get into a fight about who knows what. We all know that we're professionals, we're here, and we have to keep coming. They are asking for a solution.
Well, there are solutions. The thing is, they believe what they believe because they've heard from people who are telling them what they need to hear. So a lot of perverse interests. Thank